Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and today I'm with Sandeep. How are you doing today?
I'm doing well, Dennis. Thank you. How are you?
I'm doing good. Since this is the first time on the podcast, would you mind doing just a real quick introduction of yourself?
Yeah, sure. My name's Sandeep. People call me Deep. I'm an anesthesiologist, and I've had a few years of Army experience.
Sounds good. So the reason why I asked you on, because you're an anesthesiologist, and I had read a paper that you have written, you and some others, on IV lidocaine, using that in an austere type of environment. And I got to be honest, that is contra to absolutely everything I've been taught about lidocaine. Whenever we're doing a block, they say aspirate to see if you're in a vessel, and if you are, do not push it. So why on earth would we be pushing this directly into the vasculature?
Yeah, Dennis, I think that's a fairly good question. It's actually started pretty early in the use of local anesthetics in general. We know lidocaine, made first by Astra, a Swedish company, was FDA approved in the late 1940s. But I believe like 3 or 4 years after that, it had already started to be used for analgesia systemically in the intravenous setting. Currently, we do use it fairly frequently as anesthesia providers, whether it be induction of anesthesia or as part of ERAS protocols, enhanced recovery after surgery. And we find that it does a good job of providing analgesia and sparing opioids. In fact, there was a recent study published in Military Medicine by Austin Bell looking at basically the ability to provide an opioid-free anesthetic when performing general anesthesia for major surgeries. And the most common non-opioid that was used in their study was actually intravenous lidocaine. It has it does have a narrow therapeutic window, but if you follow a lot of the safety measures, particularly the dosing parameters, fairly low doses are safe in most of these patients.
Okay, so mostly just used as a opioid-sparing type drug. What kind of bang do you get out of this? Is it something that I should be worried about? That's something that I should be doing?
Yeah, so I think assessing the impact and the benefits of using this modality are important when selecting it, especially with the risk profile that comes with it. I think when you're looking for how much bang for your buck you're going to get out of this, it's probably important to compare it to other available analgesic modalities. Mm-hmm. It has been helpful, like I say, in statistically reducing opioid consumption and pain scores. But oftentimes when compared with an appropriate regional anesthesia, with respect to pain scores, opioid consumption, but also looking at further end outcomes like respiratory parameters, or for major abdominal surgeries when we look at return of bowel function, oftentimes you'll find that regional anesthetics are superior to intravenous lidocaine. Now, that's not to say that intravenous lidocaine doesn't have a role. We, as some of the benefits I've mentioned already, there was an important study after mastectomies where I believe Chu and colleagues, I stand corrected, Turkawi and colleagues out of University of Virginia found that actually not just acute pain outcomes were improved, but long-term outcomes were improved. I think they looked at pain up to around 6 months-ish. Again, this doesn't necessarily apply directly to the austere environment, but there's some promise to improving pain in the short term and improving pain in the long term as well.
Okay, so surgical pain, I definitely get it. Having had surgery, it does hurt afterwards. Can I essentially extrapolate that same type of information when I'm talking about trauma or pain from just damage from trauma?
Yeah, I think if again, it comes to what's in your toolkit. If you have your standard TCCC medications, your ketamine, your fentanyl, I think they're going to typically be superior to lidocaine. In the cases that I published, the provider had a limited supply of ketamine, and opioids were essentially non-existent in the environment he was practicing in. So, when compared to nothing or maybe Tylenol, lidocaine would be pretty helpful. If we're talking, management of pain secondary to traumas. If you're, in a conventional hospital, stateside, certainly including lidocaine in your management of pain in a trauma patient is appropriate. Out in the austere environment, it wouldn't be the first medication I went to.
Right. And I mean, I absolutely agree. Like, if somebody's lost their limb, I'm not going to probably reach for lidocaine as my number one drug. Ketamine, fentanyl, something like that would be something I'd go to first. But if I understand it right, at some point, you're going to start going through these narcotics fairly quickly. And maybe you have the skill to do a regional block, maybe you don't. Or even the equipment to do it. But would it be safe to say using some kind of lidocaine, maybe not as your primary agent unless you are forced to, but using it as a way to reduce the amount of overall narcotics that you're using, and then extending out your supply even longer? Would that be a better use maybe in the austere?
Yeah, Dennis, I think you nailed it, and I think that's exactly what we saw in the I shouldn't even say paper, in the case report that was published. Mm-hmm. Is the provider had limited access to traditional or conventional analgesics. I think Tylenol and ketamine were the only alternatives that he had at the time, paracetamol. And without many modalities to go to, and without the training in regional anesthesia, the provider opted to use a low dose lidocaine infusion, which helped in both of the cases that were mentioned in the publication, and did not experience significant side effects from it. And with we'll probably talk about safety quite a bit whenever we're discussing IV lidocaine. There are some important safety parameters. International consensus was published by Fu and colleagues in 2021, and I'm going to speak, Dennis, in terms of conventional clinical practice, and I'll let you folks be the ones to determine which are applicable in the more austere environment. But first and foremost, make sure whatever institution you're working with has approved your protocol. So we talk about low doses. We're talking 1 to 1.5 milligrams per kilogram per hour, or 1 to 1.5 milligram per kilogram bolus. Consent should be obtained. Obviously, the patient, if they're able to, should know the risks and benefits. Using ideal body weight is probably most helpful, as opposed to going with your actual body weight. Don't do this at the same time as your other local anesthetics. So again, the reason we oftentimes find providers carrying carrying local anesthetics in this setting is they intend to use it for soft tissue, like local soft tissue infiltration, or a regional anesthetic. It's important to make sure that you're not doing a regional anesthetic and then infusing lidocaine on top of it. We mentioned the loading dose. In addition to the loading dose or that infusion, these modalities should not be continued for greater than 24 hours. We don't want these local anesthetics to build up and result in toxicity. As indicated in the cases that were published, monitored bed space is ideal. Things like EKG, pulse oximetry, blood pressure manometry, going to be helpful. And then this is the one that gets most controversial, but the antidote for it is having lipid emulsion readily available. And just about anywhere I practice, this is the case. Obviously, in the setting of special operations forces or simply austere providers, you may not be able to carry this because it requires strict temperature control to maintain integrity of it. So I think the safety needs to be brought up whenever we're considering using this.
Okay. So let me try and unpack some of that. Let's just start off with the opioid sparing, like, I guess, how much have you seen, how much of a reduction in overall opioid use? I know everybody's different, but, you would have a general expectation anyway. How much reduction are we actually talking about? If it's like a couple of milligrams, one direction or the other, at that point, it doesn't even matter. But if it's like a significant effect, then I would say it's definitely worth attempting, at least.
Yeah, so I think the question you bring up is pretty important in this context. I wish I could honestly give you hey, if you use intravenous lidocaine, you're going to spare 4 milligrams of morphine every hour. And that's not the case. I think with different patients, you're going to find different outcomes.
Sure.
Whether acute pain or chronic pain, you're going to see variable effect on each of your patients. I referred to Austin Bell's previous publication. When using lidocaine as part of a multimodal analgesic regimen, so this is including, say, Tylenol and magnesium, ketamine, lidocaine. When lidocaine, is a part of it, you're often able to completely spare opioids. So I wish I could answer your question, very, very specifically and say exactly how much, quantity of opioid or how reduced your pain scores are. I think the patient selection and the dose of lidocaine that you use are important in that. But, as I mentioned, you got a traumatic limb amputation, doing intravenous lidocaine compared to, femoral nerve and sciatic nerve block. You just can't compare the two. Yeah. Lidocaine is not nearly as potent. IV lidocaine is not nearly as potent of an analgesic as most of your regional anesthetics.
Right, and that makes sense. A regional block is attacking, the specific nerve directly, and you can use, like your ropivacaine or bupivacaine and get hours upon hours of coverage and full, blockage of any kind of stimulus versus an infusion of lidocaine, which in itself, if you use that as some kind of regional agent or local agent, you get an hour-ish out of it. So that 100% makes sense why a regional block would be a little more effective because you're targeting the problem itself. When you mentioned dosing, okay, bolus 1 to 2 mg per kg, and an infusion, again, 1 to 1.5 mg per kg per hour, no longer than 24 hours. But you mentioned dosing it by ideal body weight versus actual body weight. I guess why? Yeah,
so typically when we're infusing these medications that have a narrow therapeutic window, it's important to think of where that medication is going to be, particularly in its availability to the organs at which its toxicity is important for. Local anesthetics are typically weak bases, and they are designed as such because they need to be able to, at a physiologic pH, they need to be able to have basically be in a state where they have no charge and enter the neuron, and then quickly be able to gain a charge. So, with that being said, when we're dosing these medications, we expect that they are going to have their charged and uncharged forms in some sort of a balance, right? And as these local anesthetics change in availability depending on the tissue that they're in, it's difficult to predict how their effect is going to be. And because of that, a patient who's larger in whom you may be bolusing a whopping intravenous dose, when that medication becomes available at any given tissue, if it's higher than what you would expect, say in cardiac tissue, you provide more local anesthetic that is available at that site, and you have more protein binding, then you're going to have more basically suppression of that conductivity in the heart, and that's where we see cardiotoxicity, particularly in the form of heart block. So More often than not, when you dose by ideal body weight, you're going to be underdosing and avoiding toxic levels of that medication.
Okay. All right. That makes sense. To find my ideal body weight, is it all right to use the same charts that I would for like my vent management, where you go by their height and, male, female, and then that gives you like an ideal body weight to at least start?
Absolutely. That's what I typically do. The two important variables are height and gender. Okay.
So you had mentioned several times about patient selection. So, I guess, where in the continuum of care would this start? Where would you even consider doing this? And what patients would you say, like, this is the guy that I can do this on? This is the guy I cannot do this on.
Sure. So I think it's pretty easy to start ruling out patients. There are pretty good protocols for this. Patients who I would not do this in start off extremes of ages. So super young children, your pediatric patients under a year, under 4 months, elderly, 65, 70 years old or greater, I probably wouldn't do. Patients who already have heart failure. We talked about the issues with cardiotoxicity, and particularly dysrhythmias that arise from excess local anesthetics. We know that these medications have to be metabolized in the liver and often excreted by the kidneys. So renal function or hepatic dysfunction. And then in pregnancy, we try not to dose intravenous lidocaine or any local anesthetic for that matter. In fact, we take extra precautions with our neuraxial anesthetics as well, spinals and epidurals. We know that the parturient is more susceptible to just about any anesthetic, but particularly local anesthetics. And there's a theoretic concept of ion trapping. Earlier I discussed that these local anesthetics are able to gain a charge and become like a positively charged ion, and it makes them less likely to pass through a lipid barrier. So what theoretically could happen is the fetus can become susceptible to toxicity because the fetus typically has a lower pH, more likely to protonate these local anesthetics, and thereby holding them within the fetus and not letting them distribute it between mother and fetus. So, again, I think to summarize, kidney dysfunction, liver dysfunction, extreme age, heart failure, and pregnancy. In those patients, I would not use intravenous local anesthetic. In selecting patients who I would use it in, I will be honest, in conventional practice, and even when I've been practicing in more austere environments, I would say lidocaine, intravenous lidocaine I use it in a majority of my patients in whom I'm performing a general anesthetic on. There's some good data to suggest that intravenous lidocaine blunts response to laryngoscopy and is also going to reduce your sympathetic responses to surgical stimuli. So if a patient is does not meet a contraindication, I will more often than not be using intravenous lidocaine because I find it so beneficial as part of my anesthetic in reducing pain and the response to painful stimuli.
Okay. 100% makes sense. The very young, the very old, generally are more susceptible to lots of things anyway. That makes sense. Obviously, you already have a heart condition. Maybe a dysrhythmic is probably not the greatest idea to push into them on purpose. And then, obviously, hepatic failure or dysfunction, renal failure, dysfunction. Again, those things all make sense. Now, when we throw out, say you have like the perfect candidate. He's a young, healthy, or normally healthy, male, female, middle-aged, right? Like they're the picture of health. And And then we throw on trauma on top of it, where they have acidosis or they're, respiratory, some kind of respiratory dysfunction, where their CO2 is really high or really low, or in their oxygenations are up and down. Is this a situation where it's like, maybe you need to get this guy resuscitated first, use your agents as you need to, and then this is like an after thing, or do you do it from the outset?
Yeah, I think it's a pretty good question, Dennis. I go back to the basics in these situations. Whether you're think as a provider on the battlefield and performing T-TRI-C, or in a hospital setting where we use the ATLS algorithm. But it sounds to me like at that point, your ABCs or your initial march is becoming more of a pressing matter than analgesia. And, while we want to do our best to make our patients as comfortable as possible, we got to remember first, do no harm, right? And, I think, a patient who's already acidotic, a patient who's, hypotensive, has altered mental status, you're likely to do more harm than good by jumping on early intravenous lidocaine. And I mean, honestly, from the sounds of it, some of these patients who are truly unstable, oftentimes they don't warrant any analgesia initially until you can really start that resuscitation. As TCCC indicates, maybe ketamine at the most. But yeah, I certainly wouldn't be jumping on pushing intravenous lidocaine before my resuscitation is started.
Okay, so this is, if you had to, ruck, truck, house, plane type thing, this is probably house type situation. We've gotten things stabilized. He's gotten some blood. We've got him oxygenating again. We have things under control, and now I'm making these little tweaks to extend out my narcotic supply and take care of the patient while we're moving him along towards evacuation.
Yeah, exactly. I mean, and I think, Dennis, that right now, there's a decent amount of evidence supporting the use of intravenous lidocaine in conventional hospital settings. Mm-hmm. There's obviously, very, very little supporting its use in austere environments. So I think the exciting thing about this case report that was published is when we're looking for what providers have available to them in the austere settings, oftentimes you find yourself, with a boatload of lidocaine because you brought it for, soft tissue infiltration or subcutaneous infiltration, before you place a chest tube or before you do a cricothyroidotomy. So these medications are available at a site. And, I'm certainly, I don't want, the work of these providers who are involved to be construed in the wrong light. But the advocacy is not that, intravenous lidocaine replace what's already in place for mm-hmm. T-TRI-C, but it's more of that, hey, if you're in the prolonged field care environment and you're running low on medications, here's this intravenous lidocaine, here's this lidocaine solution. Can this safely be used intravenously? And we know that with certain parameters it can be. I think the real question is, how do we come up with a protocol or a system to where we could safely implement this modality in the austere environment? And we're still a ways from getting there. I think there needs to be, certainly more investigation before this could be recommended, on a greater level than simply, hey, I'm out of medications. What else can I do?
Sure.
Does that make sense? Do you agree with that?
It sure does. It sure does. Yeah, I mean, to me, I think this is relatively new. It's shown that it works. It was in the case study, there was a situation in extremis. It was like, I don't have enough ketamine to do this. I have some lidocaine, or I can just strangle the guy until he passes out. And like when he wakes up, I'll strangle him again. So what are my options? Well, let's at least try this lidocaine before I start strangling him. If you could, and again, not asking you to advocate one thing or another, but let's say you were in an extremist situation. You have a small amount of let's say ketamine or fentanyl or whichever your favorite one is, but you have a small amount of it, you have a long way to go. So you need to extend this out. Let's use my body weight. I weigh 100 kilograms, like on the nose. How would you dose it? How would you titrate to the effect you're looking for?
Yeah, I think that's a good question. So what I would do in that situation, so I'm assuming that the way I'm looking at it is I'm expecting many more patients, and I know if I start exhausting my ketamine and my fentanyl supply on you right now, I'm certainly not going to even have a chance at treating these prospective patients.
Yep.
And maybe, looking at you, you're a safe enough patient to where I see you may benefit from intravenous lidocaine. So what I would do is, me personally, I push IV lidocaine, like I mentioned, regularly for induction of anesthesia. So what I would start with is a low dose, a 1 milligram per kilogram bolus over, let's say 5 minutes just to be safe.
Sure.
I would expect, and this is from experience and from the publication as well, that the one side effect that you may have is tinnitus or ringing in the ears. If that doesn't go away immediately, I would hold off on giving any or completing my bolus over those couple minutes or those few minutes. Assuming it did go away, I'd complete the bolus and obviously make sure I could monitor you. Obviously, in the ideal setting, I'd have intravenous lidocaine. And then over the next few minutes, I just assess the impact. If it helped at all with pain management to where I thought you could be functional, you could perform self-care. Pain was not a distraction. It allowed you to if there were no other confounding factors or complicating injuries, if it could allow you to have the pain relief, to sleep appropriately, to eat appropriately. Awesome. It sounds like it's going to be good enough for me. It's a modality I could continue. So I would do exactly what they mentioned in the paper, and that is ensure ongoing boluses or infusions of 1 milligram per kilogram per hour. Ensure that I don't exceed that 24-hour window, and just continue to reassess until maybe pain started to improve. Other analgesics became available, or depending on what the pathology was, if I was able to correct that pathology somehow and improve the pain, then maybe I could start to slowly wean off that intravenous lidocaine or stop with the boluses.
Okay, makes sense. From a bolus, like how long of an effect would you expect out of that?
Yeah, so the typically we're going to start to see the acute effect of the acute analgesic effect of the intravenous lidocaine within less than an hour. Most of the times I've run these infusions, we're talking 45 minutes, 30 minutes sometimes, where it's worn off. I think it's truthfully, it's probably a tough question to answer given the evidence for improvement of chronic post-surgical pain. I think I mentioned Turkawi's article earlier. Ketamine we've seen have this effect in some settings where we administer ketamine, and if you give it to one group and not another group of candidates, the group that got the ketamine may have better chronic pain outcomes than the group that didn't get it. So we don't know exactly what mechanism there is for intravenous lidocaine for that. Certainly it could be the sodium channel blockade, but there is some evidence at therapeutic concentrations that lidocaine has similar NMDA activities, not to the extent of what ketamine does, but it is able to block NMDA receptors at therapeutic concentrations.
Okay, so initial bolus. All right, and you're targeting. I wouldn't say you're targeting, but your stop point anyway is some neurologic signs. So you mentioned tinnitus. I've also read things like tingling in the tongue, some dizziness, things like that. But those neurologic symptoms, from what I've read, they start relatively soon compared to cardiovascular effects. So if you don't blow past those neurologic effects, at least cardiovascularly, you will still be safe.
Yes, that is correct, and I want to be very clear about this. We are talking only about intravenous lidocaine,
Yes.
not other local anesthetics. Regarding the specific safety profile, there's a I'm trying to recall the paper, but there's a paper that describes basically the ratio of drug required for cardiac toxicity versus that of neurologic toxicity. And lidocaine is one of the more favorable profiles with respect to this, basically meaning that when you get neurologic symptoms from intravenous lidocaine, you still have a ways to go before you get cardiovascular toxicity. Whereas when we talk about ropivacaine or bupivacaine, the moment you start to see neurologic symptoms, you're already pretty close to cardiac toxicity. So to give you kind of a reference for intravenous lidocaine, at very, very low doses will you get tinnitus and perioral numbness. We're talking 5 milligrams per ml, 7 milligrams per ml, if you will. As you start to increase to, say, sorry, I misspoke. Not milligrams, we're talking micrograms per ml. Perioral numbness occurs at approximately 5 micrograms per ml. Tinnitus, sometimes vertigo around 5 to 10-ish. As you get higher within that window of 5 to 10 micrograms per ml, you start to have more muscle twitching, slurred speech. As you exceed this, and let's say you kept increasing your dosing, and you got your serum concentration around 10 to 15 micrograms per ml, this is when we start seeing seizures and loss of consciousness. And then way up at 15 to 25 micrograms per ml is where we start to see apnea and hypotension, cardiovascular collapse, your cardiac dysrhythmias, coma. So, like I say, compared to other local anesthetics, lidocaine does have that profile where if you're having those initial neurologic symptoms, you're not necessarily close to cardiovascular collapse. But if I started to see any of those, I'd stop the infusion or the boluses.
Okay. And that kind of brings me to the other thing. Normally when I start an infusion, I do a bolus up front. I kind of figure out where this particular drug reacts best with this particular person, and that way I can set up my infusion with a little bit better accuracy to maintain that infusion and try and maintain that concentration for however long I want it to run for. Is that similar with lidocaine, where you want to do a bolus and then infusion to maintain?
Yeah, I think so. Quite a few of the literature supporting intravenous lidocaine infusions, to achieve a steady state rapidly, a desirable steady state rapidly, they'll do that initial bolus followed by an infusion. In the way I typically practice in the operating room, I will do just that. If I were using this not as a combination in the regimen of a general anesthetic, and I were just using it for analgesia, I think it'd be reasonable to just start an infusion and see how the patient does with that, as opposed to bolusing. But certainly, as long as you're following the low dosing, you bolus at 1 milligram per kilo, see how they do, wait an hour, and then start the infusion. I don't see anything wrong with that. You're still keeping your low serum concentration.
Right. Now, I think a lot of benefit would come from the patient being able to talk, so they can tell you things like, I have tinnitus, or my mouth feels numb, right? If they have an airway, they're not able to do those things. If that's the situation, would you just stop at, say, like 1 milligram per kilogram and be like, okay, that's as far as I'm going to go because I can't really assess very well, and then use my other agents on top of it to achieve the effect that I'm looking for? Or or is there another assessment I can use for somebody who can't talk or communicate?
Well, just if they're unable to talk or communicate, I'm typically not giving any analgesic.
Okay. Well, I mean,
seems,
I didn't mean like not able to communicate because they're in shock. I mean, unable to physically communicate because they have a tube in their neck.
Okay. Yeah. So I typically, I will typically keep the infusions at 1 milligram per kilogram within, each hour. Mm-hmm. If it seems like, say they seem agitated, they're localizing or withdrawing to pain, they have, a high sympathetic tone as though they were in pain. So I believe the patient were in pain. I would no longer, stack more lidocaine on top of it. I'd simply supplement with some other analgesic. There's a good chance that you're not going to require too much because you already, have some analgesia from your intravenous lidocaine. Right. I hesitate from, bolusing excessive amounts of lidocaine because of the concern for toxicity. Does that answer your question?
No, absolutely.
Okay.
I was just looking. So essentially your dosing or your assessment is the same for any kind of infusion. You're getting a sympathetic response, his respiratory rate's going up, his heart rate's going up, and I'm doing something painful. He probably is feeling pain. We're going to, intervene with some kind of agent, right?
Yeah, absolutely.
Essentially, this is no real difference. I'm going to try and if he can't communicate and I can't assess exactly where he is, I'm just going to leave that as like some kind of background coverage, and then just giving small doses of my other agents to get them over the hump and, essentially move on.
Oh, absolutely. Well, I think, along those lines, if we were to use any analgesic, mm-hmm. You almost have to, in these complex, situations, you almost have to consider applying a multimodal analgesic regimen. So if we thought about Tylenol, right? I will give Tylenol, particularly a patient who's not consuming, hepatotoxic agents or drinking alcohol, someone who's not cirrhotic. I'd consider giving between 3 and 4 grams per day of Tylenol, but I wouldn't exceed that if they're having more pain. I would simply look to another agent just to avoid the risk of hepatotoxicity. And I think the same principle goes with just about everything, and certainly lidocaine. I give a dose that I find is a safe range, particularly if I'm practicing in a non-traditional, non-conventional environment. And once I reach that dose, which should give me some analgesia, I reassess the patient. If I'm not comfortable escalating dose, then I simply look to an alternative agent, understanding that, using different modalities allows me to tackle pain without reaching a toxic dose of one of those single agents.
No, absolutely perfect. So just different than lidocaine, you talked about Tylenol, paracetamol, and patients who drink. I know in the military, we don't. That's not done. But in other places, they do. If I suspect, this guy drinks, or his friends tell me that he does drink, like how big of a concern? How do I investigate further? Is it like, well, did he have any today? Or is it like, his kind of, I don't know, life habit or social habit that he does drink? Well, then you don't get Tylenol.
So you're asking, how do I see if somebody has, I guess like a long-term hepatic issues or long?
No,
I think if I saw any signs of cirrhosis, if I even got that history, if I have an alternative analgesics, I'd certainly go to those and avoid the lidocaine.
Or the Tylenol, you mean?
Sorry, the Tylenol, not lidocaine. Sorry, I've been talking about this for too long. Yeah. And if they have, ongoing reports of like weakness, fatigue, if you see like the vascular manifestations of cirrhosis anywhere, certainly wouldn't be given lidocaine then. Jaundice, things like that. Wouldn't be given it. Also, if there's, you're likely not going to have the ability to perform laboratory assessment. But if you did have knowledge of any of their labs, if they did have any, history of cirrhosis, I certainly either avoid it or reduce dose.
Okay. Yeah, cool. When it comes to just IV, jumping back to IV lidocaine, I guess, when you talked about, further research is needed, I guess, what else do you need?
Yeah. So I would actually start in a slightly different direction. I personally feel that lipid emulsion, which is the antidote for local anesthetic toxicity, I think finding ways to make this more available in the austere environment will go a long way to making intravenous lidocaine safer. The ASRA, the society that I'm actually a part of, has a pathway for treatment of local anesthetic toxicity. And, one of the cornerstone is you modify your ACLS, obviously, calling for help, but essentially giving the antidote, which is lipid emulsion. And there's ongoing interest in trauma resuscitation and using lipid emulsion. Again, this is in its earliest stages. Mm-hmm. There are quite a few publications on various toxicities from various agents that may be amenable to lipid emulsion as well as the local anesthetics we're talking about. So, if there was growing interest in or even the ability to carry intralipids, it certainly would make administration of local anesthetics safer. Now, if that's not the case, I think we need to look into protocols that, may be safer when your ability to monitor the patient or administer the antidote is compromised. So, for instance, we mentioned there's some protocols that, in hospitals, they go up to 3 milligrams per kilogram or even higher in some of them. You certainly would not be advisable to do something like that in the austere environment. Mm-hmm. Well, I think the question is there a safe dose to give when these safety measures are not in place? And right now the answer is probably not, but I get to say that in the setting I practice, and you obviously don't. Mm-hmm. So, I think simply getting reps in the austere environment where we get more data back from that to say, hey, X number of providers have used this, or and I certainly wouldn't push for its use right now, but if we could find a safe dose that could reliably be used without toxicity, maybe it would be more appropriate for the austere environment. What are your thoughts? Does that make sense to you? You practice?
It absolutely does. I do have a blood cooler. Obviously, the priority goes to keeping the blood cool, but I would imagine that cool is at the same level as the lipids need to be cool. I guess how much of the lipid emulsion do you need?
Yeah, that's probably important to know if we're going to give it. So the concentration is 20%. Lipid emulsion. When you first notice your local anesthetic toxic event, you typically want to bolus 1 ml per kilo over 2 to 3 minutes. Following this, you want to infuse about 1/4 ml per kilo per minute. You can repeat boluses, you can double the infusion. You just don't want to you don't want to exceed 12 milligrams per kilogram. For that patient's actual body weight. I will be the first to admit I've had, from doing many regional anesthetics, I've had, quite a few episodes of local anesthetic systemic toxicity in patients. And when I have administered intralipid, the effect is almost immediate. Okay. So it's a very effective medication. And Dennis, if we had time, I could go over the entire treatment if you run into local anesthetic. Because I think it's important if you're using opioids. Obviously, you got to know how to bag the patient. Maybe it's a good idea to have some Narcan too. Naloxone. I think probably important to know how to treat your local anesthetic systemic toxicity.
Yes, please.
So I mentioned ASRA, American Society of Regional Anesthesia, has a great checklist for this. First thing you're going to do is stop administering your local anesthetic. If you have a rescue kit, which should include, resuscitation medications and whatnot, get your local anesthetic systemic toxicity rescue kit. If you have the ability to do cardiopulmonary bypass, obviously, Dennis, your setting, probably not, but some of our hospitals, or if we're working with, local nationals, maybe they have something. Administer your intralipid as early as possible. If your patients have seizures, this is where you got to start digging in deep in your kit. Grab that benzodiazepine that you typically keep for anxiety when you're using ketamine. Benzos are preferable to propofol. Propofol can also abort the seizures that local anesthetics cause. But propofol comes with two issues, obviously, well, a number of issues actually. Probably more cardiovascular instability. Propofol is a myocardial depressant, so that combined with the depressant effect that the local anesthetic has are going to kind of compound your issues with cardiotoxicity. And then, propofol can render you apneic or is more likely to render you apneic than a benzodiazepine. If you do have cardiovascular collapse, we're not so concerned about your systemic vascular resistance. We're more concerned about your, the inotropic suppression that the local anesthetic is causing. So you're going to reduce your epinephrine dose, mainly to take advantage of those beta agonist effects. And you're going to reduce the dose to 1 mic per kilo. You're going to avoid beta blockers for this exact reason, the calcium channel blockers as well. And then regarding the SVR state, you want to avoid vasopressin during the resuscitation. And then this should be obvious, but the local anesthetics were included in previous iterations of ACLS. You never want to give additional local anesthetics if you have local anesthetic systemic toxicity. That's just important because if you do have ventricular dysrhythmia, lidocaine actually used to be considered a treatment. It is still considered a treatment, but not necessarily part of ACLS. We already mentioned your dosing for intralipid. Once you've completed your resuscitation, assuming that the patient's stable, this also assumes you haven't started cardiopulmonary bypass. But if patient just had a seizure that you aborted, you definitely got to observe them for at least 2 hours. If you treated cardiovascular instability, you need to keep eyes on these patients for 6 hours or more. And if they had a complete cardiac arrest, you're probably going to need ICU level care for a while if it's available.
Right. You mentioned watching them for 6 hours. That doesn't mean an infusion over 6 hours. You're just especially with, I would imagine, a drug that lasts roughly 45 minutes. You shouldn't have to exceed that period of time for that dose if you're stopping it.
No,
this is
with
the lipid emulsion.
Yeah, this is after your lipid emulsion has been administered and your seizure or your cardiovascular instability is no longer present. Yeah. If we're talking cardiovascular instability, you after your infusion, watch them for 6 hours does not necessarily mean you need to continue that infusion for those 6 hours. Okay,
perfect. Just in your experience, does one vial generally take care of it, or have you had to use multiple?
No, every time I use intralipid, it comes in a bag, just like your IV solution.
Okay.
Yeah. So, and this is the issue. It takes up a lot of space, and it's a heavy medication. You're probably giving anywhere from, in an initial bolus, anywhere from 100 to 200 mLs, maybe in your really large patients. Okay. So it's not there. There is an investment to carrying intralipid. The saying, ounces or pounds. Right. If there's not a lot of utility for it, it's hard to argue for carrying lipid emulsion. Mm-hmm. But I think as there's more and more research into the benefits of lipid emulsion in toxicities of various agents or in resuscitation, maybe in the future there'll be more of a role for carrying it around in austere environments.
Yep. Cool. Is there anything else you'd like us to know?
No, I think we covered just about everything.
Perfect.
Well, Dennis, I guess I just have a question for you.
Sure.
Given your knowledge of the narrow window, where do you see local anesthetic or intravenous lidocaine?
Okay. So when I think about something like that, just on general principle, I'm always a very paranoid person, which is why I generally am fairly prepared when it comes to my kit and my clinic and things like that. So I'm imagining like I'm in a cave and this is like World War III and we're going to have a bunch of patients. So just as general practice, I'm going to have to figure ways to extend out my stuff. And lidocaine, I found it essentially to be in a lot of different places all over the world. So I haven't found it to be uncommon that I wouldn't be able to get it in like Europe or Asia or anywhere else. Where I think I would do, okay, I don't think it would change my treatment on the X, 1 iota. I would want to have this person fully resuscitated, like we are cruising now, and essentially I'm kind of in like the, I don't know, critical care, nursing care, extended care type phase where nothing really exciting is happening. Essentially, we're all trudging along until I can get this guy out of here. That's when I would think to start using it. Ideally, this person is able to talk to me. I think you're the idea of a 1 mg per kg slow bolus is absolutely acceptable. I think as long as this guy can communicate, I'll know if he starts, getting, and I warn the guy, hey, like you might get ringing in the ears, or you might feel tingling in the tongue or mouth, or you might feel dizzy. Like let them know to look for these things. When they feel them, I promise they'll let you know. And then just do a nice, slow, easy push. Wait till they start to feel that. At least now I know I'm probably starting to touch those neurologic toxicity levels. Stop. Like you said, those feelings should go away as this drug redistributes through the body, and that concentration of the blood kind of distributes everywhere. 1 or 2 bumps of those, I will have a very good idea about what my infusion should be, and I'll have time to make an accurate drip calc and set up a bag that's easy for me to run. Not expecting at all that this is going to cover a patient 100%, but if I can squeeze, a 25% reduction out of it, I'll take it. Then turning more towards maybe my shorter acting agents, your ketamine, maybe fentanyl, whatever you feel is appropriate for that patient, and then stack those things on top to actually achieve the analgesic effect I'm looking for. That's where I would see this fit in. I don't imagine me carrying a lipid emulsion. It's more of the safety is in my ability to assess the patient, and if I don't think I can assess them appropriately, maybe this is not a wise thing to do. I don't know. Did I win?
No, I like that. That's exactly what I feel like. You and I are on very similar pages with this concept.
Yeah. I 100% agree. I really like the idea of using a non-narcotic agent to extend out my other ones. I get the feeling, reading a lot of research, they talk about opioid-sparing and things like that, the opioid-free emergency department, etc., because they're worried about the opioid crisis. I'm too selfish right now. I'm having my own crisis right now to worry about, adding to the opioid crisis. I need to get this person safely to somebody else. Right. So I'm thinking more of how can I use my tools most effectively to take care of the problem, take care of the patient, to get them where they need to go.
Exactly.
Cool.
Hey, Dennis, I appreciate you inviting me. You've created an awesome platform, and it's a great opportunity. And I just want to say thanks.
Yeah. Oh, thank you very much for coming on. I knew you'd know all the answers. That's it for today's podcast. Be sure to go to our website, www.prolongfieldcare.org. Find us on Facebook, YouTube, Instagram. Subscribe and stay on the bleeding edge of combat medicine. This is Dennis for the PFC Podcast. Out. Boy, it's waiting there for you.